Hi guys. So in today's lecture we will discuss a very salty condition by the name of primary hyperaldosteronism. In this condition there will be more of salt and water retention due to excess of aldosteronism, and in this particular condition we will discuss a mnemonic by the name of salt, which will be actually very productive. So let's start. So here you can appreciate excess of aldosterone and resulting into more of salt and water retention. And if this excess of aldosterone is due to adrenal tumor, this particular condition is known as Conn syndrome, whereas it can also occur due to bilateral adrenal hyperplasia or due to adrenal carcinoma. Try to understand. Most common cause of primary hyperaldosteronism is bilateral adrenal hyperplasia we will discuss, followed by Conn syndrome, that is adrenal adenoma, resulting into more of secretion of aldosterone. Now try to understand, because main function of aldosterone is to absorb more of salt and water at the collecting duct. Therefore, excess of aldosterone will result into more of salt and water retention, resulting into more of blood volume, resulting into hypertension. And that to resistant hypertension, we will discuss what is resistant hypertension. Okay. Now, you guys understand the basic thing. In case of aldosterone, the action will take place at collecting duct, and at collecting duct, it will act on epithelial sodium channels and it will facilitate sodium reabsorption, whereas it will facilitate potassium and hydrogen excretion. Therefore, in this particular condition, there will be hypokalemia, there will be less of protons in body, and this particular condition will result into hypokalemic metabolic alkalosis. So we will discuss various aspects of hyperaldosteronism in detail. Now, like other endocrine glands, you have again hypothalamic pituitary axis. Because we are dealing with adrenal gland, therefore in this case there will be hypothalamic pituitary and adrenal axis. Let's note one particular thing: hypothalamic pituitary adrenal axis. This hypothalamus and pituitary will control this activity of adrenal gland, but only the activity of zona fasciculata, resulting into more of cortisol secretion. Hypothalamus will secrete corticotropin release hormone, and it will stimulate your anterior pituitary, and then anterior pituitary will secrete ACTH, and this will act on zona fasciculata only. Therefore, it will control the secretion of cortisol only, not aldosterone. So, whenever there will be more of ACTH, we have already discussed, it can result into more of cortisol, and this particular condition can result into Cushing syndrome. In case ACTH decreases, cortisol can also decrease, and this particular thing is determined by HPA axis. Whereas control of your zona glomerulosa happens due to renin-angiotensin system, that is your RAS. Try to understand. We have been studying about renin-angiotensin aldosterone system. This is independent of HPA axis. Whenever blood volume in body decreases or whenever patient suffers from hypotension, it will result into activation of juxtaglomerular complex, and this will result into more of secretion of renin. Now this renin will activate angiotensinogen, and therefore angiotensin will be formed, and this angiotensin will act on adrenal cortex, particularly at zona glomerulosa, resulting into more of secretion of aldosterone. So this particular thing will result into more of aldosterone. Now try to understand. This particular thing involves your renin, angiotensin and aldosterone. Therefore, it is known as renin angiotensin aldosterone system. Therefore, your zona glomerulosa is mainly controlled by the activity of renin and angiotensin. Now try to understand one basic thing. In case of hypovolemia, you can understand that this renin will be responsible for increase in aldosterone. So this particular condition is known as secondary hyperaldosteronism. In this particular lecture, we will mainly talk about primary hyperaldosteronism. So this RAS activation results into secondary hyperaldosteronism. This has to be understood. Okay. When aldosterone increases primarily due to hyperactivity of zona glomerulosa due to any reason, this particular thing is known as primary hyperaldosteronism. This is secondary because this is happening due to increased renin. Now let's recap. Here you have adrenal gland And we have already discussed that outermost layer is glomerulosa, then you have fasciculata, and then you have reticulata. We have already understood all these things. This zona glomerulosa secretes aldosterone. Whenever this zona glomerulosa secretes lot of aldosterone, this will be considered as primary hyperaldosteronism, and main cause of this primary hyperaldosteronism is your bilateral adrenal hyperplasia followed by aldosterone producing adenoma, right? This is APA, and this particular thing is also known as Conn syndrome. So these are important causes which can result into primary hyperaldosteronism. We have already discussed that for secondary hyperaldosteronism, renin has to be increased along with increased activation of angiotensin, and then in turn it stimulates your adrenal cortex resulting into more of aldosterone. This particular condition is your secondary hyperaldosteronism. Okay. In this particular lecture, we are going to focus on this particular part. Let's recap. Here you can appreciate renin-angiotensin-aldosterone system responsible for activation of zona glomerulosa, resulting into more of aldosterone. Whereas in case of cortisol secretion, that is action on zona fasciculata, this HPA axis operates. So you have different mechanisms for the secretion of different hormones of adrenal cortex, whereas your adrenal medulla is independent part. It is again not controlled by your HPA axis. So this has to be understood. In this particular lecture, we will discuss excess of aldosterone primarily due to adrenal gland itself, that is known as primary hyperaldosteronism. So here you have different causes of primary hyperaldosteronism. Try to appreciate that primary will be independent of renin-angiotensin system. It will be in fact due to aldosterone secreting adenoma. It can be due to bilateral adrenal hyperplasia, and rarely this can be due to cancer of adrenal glands. Okay. Now, there will be various clinical features we will discuss one by one. Try to understand. In this particular condition, we have already discussed that there will be more of salt and water retention at the level of collecting duct, and this will be primarily resulting into increase of sodium. And whenever sodium increases, it is at cost of hydrogen, it is at cost of potassium. Therefore it will result into hypokalemic metabolic alkalosis. So this is basic understanding in context of your hyperaldosteronism, and in this lecture we will also discuss a mnemonic by the name of salt. So keep your fingers crossed. Okay. Here you can appreciate probable causes which can result into primary hyperaldosteronism. That is, problem will be in the gland itself. That is, problem will be mainly related to zona glomerulosa. This is your adrenal adenoma, and this particular thing results into Conn syndrome. And then you have bilateral adrenal hyperplasia. These two causes are more important, and this is most common cause of primary hyperaldosteronism. Okay. Let's proceed. Let's talk about the pathogenesis. You guys understand that aldosterone acts at collecting duct primarily at your epithelial sodium channels. This epithelial sodium channel is responsible for more of sodium reabsorption. Along with sodium, water also comes in. And along with this will also stimulate excretion of potassium and excretion of hydrogen. Too simple to understand. So major development in case of primary hyperaldosteronism is your hypernatremia along with hypokalemia and metabolic alkalosis. Try to understand, this will result into hypokalemic metabolic alkalosis. Therefore, pH will be higher than 7.40. Okay. So this is the actual pathology in case of primary hyperaldosteronism. And because there is more of water reabsorption, it will result into more of blood volume, and therefore patient's blood pressure will increase. And now we will discuss that in this case patient might have resistant hypertension. Okay. Here you can again appreciate the same thing. At collecting duct, you can appreciate the presence of epithelial sodium channels resulting into more of salt and water retention. Try to understand one more thing over here. Here you can appreciate one more condition by the name of Liddle syndrome. In case of Liddle syndrome, which is differential diagnosis of primary hyperaldosteronism, there will be increased activity of this epithelial sodium channels. It will be independent of aldosterone or renin. Try to understand. This will result into increased activity of epithelial sodium channels. So, this will become autonomous. This will start hyperfunctioning, resulting into more of salt and water retention, more of potassium and hydrogen loss, resulting into again hypokalemic metabolic alkalosis and hypernatremia and hypertension as well. So this Liddle syndrome is differential diagnosis of your primary hyperaldosteronism. In this particular condition, there is increased activity of epithelial sodium channels, and in this particular condition, we will use amiloride or trimethoprim in the treatment. We will discuss, and particularly we will make use of the mnemonic salt in understanding primary hyperaldosteronism along with Liddle syndrome. Okay. Now let's recap and also discuss clinical features of bilateral adrenal hyperplasia. Here you can appreciate aldosterone producing adenoma. This is your Conn syndrome we have already discussed. And then you have most common cause of primary hyperaldosteronism, that is your bilateral adrenal hyperplasia. Let's understand the clinical features in detail. We have understood that this will result into hypertension primarily due to increased activity of epithelial sodium channels due to this increased aldosterone. Here you can understand that it will result into hypertension, but this hypertension will be resistant in most of the cases. By resistant hypertension, I mean to say that this hypertension might not get controlled even after giving 3 antihypertensive drugs, and one of them should be your thiazide diuretic. So this can result into resistant hypertension. Here you can understand that this hyperaldosteronism can result into hypokalemia and also metabolic alkalosis. This hypokalemia can result into muscle weakness and sometimes even paralysis, muscle weakness, and therefore patient will experience lot of fatigue. Now let's talk about the investigations required for the diagnosis of primary hyperaldosteronism, secondary hyperaldosteronism, and also Liddle syndrome. Here you can appreciate that this patient is having hypertension along with hypokalemia, and this hypertension is mostly resistant hypertension. Now, you have a screening test for the diagnosis of primary, secondary hyperaldosteronism and Liddle syndrome, and then you can confirm your diagnosis with help of imaging tests. We will discuss each and every tool required for the diagnosis of hyperaldosteronism. Here you can appreciate your screening test, and your main screening test is your aldosterone-renin ratio. Try to understand. You have to employ your plasma renin aldosterone ratio as major screening tool for the diagnosis of primary hyperaldosteronism, secondary hyperaldosteronism, and also Liddle syndrome. So this particular thing is known as ARR, that is aldosterone-renin ratio, and try to understand this particular hierarchy, that is renin angiotensin aldosterone system. You have renin at the top, and then you have angiotensin, and then you have aldosterone. So this aldosterone renin ratio will be very helpful as a screening tool for the diagnosis of aldosterone related problems. Try to understand. You have renin angiotensin aldosterone system. In case of primary hyperaldosteronism, there will be problem at the level of adrenal cortex resulting into more of aldosterone. So this aldosterone will provide negative feedback to renin, and therefore renin levels will decrease. So in case of primary hyperaldosteronism, more of aldosterone will be secreted from adrenal cortex in autonomous fashion, and therefore in case of primary hyperaldosteronism, ARR ratio will increase. Try to understand, in this particular case aldosterone will increase and renin will decrease, and therefore ratio will increase. Whereas in case of secondary hyperaldosteronism resulting due to increased renin, increase in renin will result into more of stimulation of adrenal cortex, particularly zona glomerulosa. So in case of secondary hyperaldosteronism, there will be fall in ARR ratio because aldosterone will increase, whereas denominator, that is renin, will also increase. So this will result into decreased aldosterone renin ratio. And now try to understand what is going to happen in case of Liddle syndrome. In Liddle syndrome, we have already discussed that everything will be fine, but there will be more of activity of epithelial sodium channels. And because this epithelial sodium channel has become autonomous, this will inhibit aldosterone as well as your renin. So in case of Liddle syndrome, problem will be little different. These channels will become very hyperactive, and these channels will function by themselves. So in case of Liddle syndrome, both aldosterone as well as renin will decrease. So in this particular case, ARR will stay normal, that is aldosterone as well as renin both will decrease, and therefore ratio will come out to be normal. Okay, so this is basic understanding of the main screening tool for the diagnosis of primary and secondary hyperaldosteronism along with Liddle syndrome with help of plasma aldosterone-renin ratio. Here you can appreciate your screening test. Now you can employ one more screening test over here, that is your saline loading test, saline or salt loading test. Now we are done with two screening tests. You have aldosterone-renin ratio and saline or salt loading test. This should be your investigation of choice. Okay. Now let's confirm our diagnosis. For confirmation of diagnosis, you guys will need to localize the tumor. You guys will need imaging test. So in this particular test, you can go for imaging test in form of CT or MRI abdomen. This will pick the adrenal tumor, and this will also pick the bilateral adrenal hyperplasia. So for confirmatory test, you can go for imaging test, particularly CT or MRI of abdomen. Now, try to appreciate, sometimes tumor size can be very small. If tumor size is less than 1.5 centimeter, it might not be picked with CT or MRI abdomen. Therefore, you can also go for adrenal vein sampling. This will be very productive. In case tumor is smaller and unilateral, one of the adrenal veins will have more of aldosterone and the other will have less of aldosterone. So this adrenal venous sampling is important investigation in case you cannot figure out this particular tumor with help of imaging, because sometimes tumor size might be very smaller. Now, having discussed the investigations, we will talk about the treatment part. And here you can appreciate that the main treatment of aldosterone producing adenoma is your adrenalectomy. Whereas in case of bilateral adrenal hyperplasia, you will go for mainly medical management. And main medical management in this case will be control of hypertension. And we did discuss that in this case, patient can have resistant hypertension. So treatment of your aldosterone producing adenoma, that is your Conn syndrome, will be mainly with help of surgery, that is your adrenalectomy. Whereas treatment of bilateral adrenal hyperplasia will be mainly by drugs. And your drug of interest over here is your aldosterone antagonist. We have already discussed that this patient might be suffering from resistant hypertension. So here drug of choice should be aldosterone antagonist, particularly spironolactone or eplerenone. You guys already understand the aldosterone antagonist. So this will control the resistant hypertension as well. Now let's discuss our Mnemonic by the name of salt. This will be very productive for the understanding of aldosterone related problems. In salt, you guys understand that aldosterone will facilitate reabsorption of salt. So this salt will be very productive, and this S represents your salt loading test. We have already understood that this is also known as saline loading test. Plus in these cases you are going to use spironolactone. And then you have A. This A is your aldosterone-renin ratio as major tool for the screening of this aldosterone related problems. And then you have differential diagnosis and another disease by the name of Liddle syndrome. And in case of Liddle syndrome, you have amiloride. Along with amiloride, you also have trimterene. So this is your mnemonic in context of aldosterone related problems. You have to always remember that you have to give aldosterone antagonist. Therefore, spironolactone and eplerenone will be treatment of choice. And in screening test, you have saline loading or salt loading test. And then you have aldosterone-renin ratio. We have already discussed this particular thing in detail. And differential diagnosis is your Liddle syndrome. So we have simultaneously discussed primary and secondary hyperaldosteronism along with Liddle syndrome as well. And you have to treat this Liddle syndrome with help of trimterene or amiloride. So now we are done with our discussion on primary hyperaldosteronism. We have also discussed secondary hyperaldosteronism over here, and we have also discussed Liddle syndrome over here. In next lecture, we will talk about Addison's disease. Bye bye. Take care.